Checking for olfactory nerve. For this purpose, you make sure that the patient hasn't got any blockage of his nose and his sense of smell previously was okay and now it has disturbed. For this purpose, we use ordinary odors. We can use soap, we can use perfume, we can use any other odor. To examine the olfactory nerve, we ask the patient to close the eyes, and close one of his nostrils. We bring the desired odor and bring to the nostril and ask the patient to sniff in. Lamba saans khecho. Okay. And then he is asked to make a note what type of smell he had. Similarly, you check for different odors after some time so that patient is able to clearly differentiate the different odors. Afterwards, you close the other nostril and check in the nostril again to make sure that the both sides are intact. The optic nerve is a second cranial nerve. This nerve, when we check it, we check three functions. Number one is the visual acuity, number two the field of vision, and number three the color vision. For visual acuity, we use the Stellan chart for the far vision and the Jaeger chart for the near vision, like I have got in my hand like this. And we check the visual acuity on both sides and we come up whether it is 6 by 6 or whether it is less or more. As far as the field of vision is concerned, we perform a confrontation method which is done like this. For field of vision, we use commonly use confrontation method. In this, the examiner and the patient sits at the same level at a distance of 1 meter or 1 arm's length. The subject is asked to close one of his eyes, and the examiner also closes his. If the subject closes his right eye, the examiner will close his left eye, and the subject will look into the examiner's right eye with his left eye. The examiner makes sure that his field of vision is normal. So what they do is that the examiner outstretches his hand and flexes his other fingers, that points out his index finger, and wiggle this index finger. Make sure the distance between the finger between the candidate and the examiner is not variable. So it moves from all direction and asks the patient whether he can see it or he cannot see it, the wiggling toe. But for this purpose, when the examiner sees the finger, when the examiner sees the finger, the subject should also see the finger as well. Now you repeat that on the opposite side. And in this way you compare the both sides, and this is the classical confrontation method for examining the field of vision. As far as the color vision is concerned, we use special designed color vision chart which is called Ishihara chart, and we show these cards to the patient, and the patient can recognize the hidden figure in it, and we make sure whether this patient is green blind or yellow blind. Now to check the light reflex. For this purpose, the patient should be sitting on a couch, and the surrounding light should be either very light. And what we do is we ask the patient to keep his eye open and we shine the light. He should be looking straight ahead without moving his eyes, and we shine the light from the side and we see the response of the, and after some times it dilates. we do it on the both sides. So consensual reflex, what we do is we put a card paper in between the eyes and we shine the light on the right eye and we see that the left eye pupil also constricts, and similarly vice versa. This is called consensual light reflex. For accommodation reflex, we ask the patient to look straight ahead, and then we bring a finger forward, look, and then suddenly he looks at the finger which is kept about 12 inches, and in this we note that the eyes, they become convergent and the pupil also constricts, and that is the accommodation reflex. Microscopic examination is an important examination as far as the command is concerned, and also as far as the neurological examination is concerned. For this we use a standard ophthalmoscope. One should be well versed with the ophthalmoscope. It has a diaphragm which has different types of lenses. The red lens, the red number shows the concave lenses, and the black number shows the convex lenses. For this, what we do is we have to instruct the patient properly. For examination of the right eye or right fundus, we stabilize the patient's right upper lid and lift it up with the left thumb. Ask the patient to look straight ahead and do not look into the light unless and until he is advised to do so. So we switch on to the ophthalmoscope and we shine the light to look for any red reflex, and then we gradually we keep on asking the patient not to blink the eyes. We gradually come across the cornea, and then we go through the pupil and we go around to all the quadrants by making a movements like that. Now for this purpose, it is important to know that when you examine into the right fundus, the ophthalmoscope should be in your right hand, your thumb should be placed on this aperture, and your index finger just to rotate the lens to focus it properly. So the principle will be patient's right eye, your right hand, and you should keep your mouth away from the patient's mouth so that you should not, or he should not, breathe into your mouth or each other's mouth. Similarly, if you want to examine the patient's left eye, the ophthalmoscope should be in your left hand. You should place your right hand on the patient's left eye and do the same procedure and go all the quadrants, up and outer, lower and outer, lower and inner, and upper and inner, and make sure you comment on the disc and all the blood vessels which you see in the retina. Check for nystagmus. For this purpose, ask the patient to sit on a couch and look straight ahead, and then keep your finger about 12 inches from the patient and ask him to keep looking. If the patient has got any spontaneous nystagmus, he will show there and then. Afterwards, by holding the head of the patient and asking him not to move his head, you keep that, you move your finger to the lateral side of the patient's eye and ask him to follow, and keep it there for 5 seconds, and then you will note the presence or absence of any nystagmus. Sometimes you have to do on the opposite side as well, and you look for any nystagmus. If you take your finger too far, then spontaneous nystagmus occurs, which is usually is normal phenomena. And then you describe what type of nystagmus was that, whether it was jerky, pendular, rotatory, vertical, etc. The ocular movement. This is important to know, and this will test your third, fourth and sixth cranial nerve. For this purpose, you ask the patient to look forward and you keep your finger about 12 inches from there and ask him to follow this finger in all the direction like this. Then you go on to the oblique. Sometimes it's important to take the patient's eye on the lateral side and then ask him to look up. By this, you can easily see whether these movements are symmetrical or not, or whether there is any weakness of any muscles supplied by these. Examination of the trigeminal nerve, which is our fifth cranial nerve. This is a sensory motor nerve, and it supplies the muscle domestication and the sensory part of the face as well, and along with the corneal supply. For this, we first of all see the supratemporal fossae, whether they are wasted or not, because of the temporalis muscle, and then we see the angle of the jaw, whether they are wasted or not, and then we see the lower jaw as well. We ask the patient to clench the teeth, and we feel and we feel for the tensing of the this superficial temporalis muscle, and then we feel for the masseter muscle. We ask him to open the jaw, and we press it for and we press it for we press the jaw upwards and on the lateral side to know the pterygoid muscles. And then we come on to the jaw jerk. For this, we ask the patient to open the mouth lightly, and then we push down the skin over the chin, and then we strike and put our left thumb, and with the head of the hammer we strike the thumb, and the patient chin moves upward, which indicates the jaw jerk. As far as the sensory part is concerned, we use this test superficial and deep sensation. Superficial sensation, you know, the trigeminal nerve has three divisions: the ophthalmic division, the maxillary division, and the mandibular division. For this, we use a cotton wisp, and we touch the patient's forehead after closing the eyes, shut the eyes, and then we ask him whether he feels anything or not, and we check it on both the sides. And we can go up to the vertex as well, because you know that the ophthalmic division of the trigeminal nerve goes up to the vertex. As far as the pinprick sensation is concerned, again ask the patient to shut the eyes, and with a pin or with a sharp toothpick you can feel for the sensation in all these three divisions, and you can go up to the vertex as well. As you know, the anterior two-thirds of the tongue is supplied by the trigeminal nerve, so it will be important to check the taste in the anterior two-thirds of the tongue as well. As far as that corneal reflex is concerned, what we do is we ask the patient to open his eyes, and he should look straight. Then, with a wisp of a cotton, which should be very neat and clean, ask the patient to look inside, and with the cotton wisp touch the cornea slightly, and the patient will blink his eyes, and that will indicate a positive corneal reflex. You can repeat it on both the sides and compare and tell your findings to them. Check for the facial nerve. Now this is an important nerve which has the important aspect in the clinical examination of neurology, and it's a commonly asked command because Bell's palsy is a very common pathology which encounters the facial nerve. This purpose, we ask the patient to frown his forehead. Can you look up? And you see that he makes the wrinkles on the forehead. Can you make wrinkles on the forehead like this? Yes. You see the wrinkles, they are symmetrical on both sides. Okay. Now, we'll ask the patient to shut his eyes and try to lift his eyes or open his eyes as much as possible. If this patient has Bell's palsy, unable to open, to shut his eyes, and the eyeball will roll up, which is called Bell's phenomena. Then you look at the patient's nasolabial fold, they are both symmetrical. Then ask him to show the teeth, and you see that there is no asymmetry of the nasolabial folds. And can you blow your mouth? Now ask him to blow the mouth and see whether you can, and press with your hand the cheeks, whether the air leaks or not. Now lower the lip, say E. 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 By this, say E. Say E. E. By this you also note the movement of the platysma. This will complete the examination of the checking the sensation of taste. I will just demonstrate how you do it. In this, you ask the patient to open the mouth and put the tongue out. Now, with the tongue protruding out, you hold the side of the tongue with your gloves on and with a cotton gauze, and you have solution of salt, sugar, and vinegar or anything which is bitter. What you do is you hold the tongue and you ask the patient to raise the finger when he feels the taste of sugar, salt or vinegar, which you will tell. Now, by holding the tongue, apply about an inch lateral to the tip of the tongue solution of sugar first, and then leave it for a while and ask the patient to raise his index finger if it is sugar, middle finger if it is salt, and ring finger if it is vinegar, and little finger if it is quinine. And by doing this on both the sides, you can come to know that the patient's sense of taste is there or not. After applying one taste, you have to wipe the tongue and apply the other solution. Make sure that the quinine or the bitter tastes are applied in the end. Check the auditory part of the eighth nerve. For this purpose, we use either our own voice, which the patient can either hear like a whisper or can hear from a distance. Number two, we can use an ordinary wristwatch. First of all, the examiner makes clear at what distance that he can hear the clicking of the watch. At the same time, brings the watch to the patient's ear and asks him at what distance he can hear the clicking. Number two is that you can take the hair from the patient's side and just crunch it a little bit and see how little movement the patient can perceive. Another important test to know the auditory part of the eighth nerve is the Rini test, which we do with a tuning fork of either 512 or 256 Hertz. So these are the prongs, that is the stem of the tuning fork. What you do is you hold the tuning fork with the stem on your right hand, and with the ball of the thumb on the left hand, you strike the prongs, and then you place that on the patient's mastoid process like this, and you ask him when he stopped hearing. Now he has stopped hearing, and then we bring the prongs in front of the ear and we ask whether he can still hear the buzzing of the fork or not. And if he can hear, it means that the air conduction is better than the bone conduction, and the Rini test is positive. The other test is called the Weber test, which is used to find out any neurological deficit in the hearing. For this purpose, again we use the same tuning fork, we strike it and we place at the forehead or the vertex of the patient, and we ask the patient which side he can lateralize the sound. Examination of glossopharyngeal and the vagus nerve. Before you go on to this examination, you should ask the patient how long ago he had his recent meal. Because if the patient has had a meal very recently, and if you do this examination, as you know that in this examination you have to touch the fossa of the tonsils, and sometimes you have to press or touch the posterior pharyngeal wall, the patient may vomit. For this, the patient is asked to open the mouth but keep the tongue inside, and then With the posterior one-third of the tongue is pressed with a tongue depressor. Ask the patient to say ah, and you see the uvula moves upwards symmetrically, and then you touch the fauciet and the patient shows the gag reflex, and this will tell you which side the fauciet moves and whether the gag reflex is present or not. Of accessory nerve, which is the 11th cranial nerve, we look at the neck for any wasting, and we look at the upper part of the trapezius for any wasting, and then we go on to the back of the patient. We put both our palms on the both shoulders of the patient and ask the patient to shrug the shoulders, and we push it downwards. If there is any weakness, that shoulder will be pushed down. Then we ask the patient to retract. The previous examination will cover the upper one-third of the trapezius. Then we ask the patient to retract the shoulders, and this will check the middle one-third part of the trapezius. And then we ask the patient to extend his arms and press forward against the wall, and that will cover the lower one-third of the trapezius. Then we go on to the sternomastoid muscle. We ask the patient to move the neck to the opposite side, and we press it on the other side, and we feel for the tensing of the opposite sternomastoid muscle. Then we do it on the opposite side, and we see that this muscle is tense. So this tells you how strong the sternomastoid muscles are, and this completes the examination of the accessory nerve. Examination of the hypoglossal nerve, or the 12th cranial nerve. In this we concentrate on the tongue. We ask the patient to open the mouth and keep the tongue inside, and we look for any asymmetry of the tongue, any wasting of the tongue, any fasciculation of the tongue, etc. Then we ask the patient to lift the tongue up, move, and we see whether the undersurface of the tongue is fine or not, whether he can move the tongue upwards, and we look at the frenulum linguae as well. Then we ask the patient to move the tongue out and see whether this tip of the tongue deviates to any other side or not, or whether the abnormal movement disappear, etc. Then we ask the patient to close the mouth and push the tongue on this side to see whether its lateral movement is fine or not. This will test the hypoglossal nerve. As far as the bulk of the muscle is concerned, you can use a bimanual examination, which has already been told before. Horner syndrome is due to sympathetic paralysis in the cervical area. This gives you 5 important signs in clinical medicine. Number 1 is that the palpebral fissure is small, which is called anophthalmos, because the eye becomes sunken due to the paralysis of the muscle of the molar. Number 2, there is partial ptosis. Number 3, there is the constriction of the pupil, which is called miosis. Number 4, there is loss of sweating on that same side of the face, which is called anhidrosis. And there is a loss of ciliospinal reflex. The ciliospinal reflex is what? That if we pinch the skin on the same side of the sternomastoid muscle, then the pupil should dilate. In this case, there is a paralysis of that reflex. And that in 5 features are important to remember as regards Horner syndrome. In the bulk of the muscles, most important thing is to, first of all, a visual comparison of all the muscles of the upper and the lower limb, and then you want to actually measure it. You just go to the middle circumference, use inchy tape, and you determine the bulk of the muscle, but you have to have a same reference point. Similarly, you do on the opposite side in the same reference point and with the same. It should not be that on one side you are measuring from the lower end of the upper limb and from the other the upper end of the upper limb, and at one time you are using the inchy tape as centimeters and the other times you are using as inches. Similarly, you can have a point, especially the bony fixed point, that is anterior superior iliac spine. From here you can have, say for example, 10 or it, about 25 centimeter from that, and then you can measure it, and at the same place, same position on the opposite side, and similarly from the tibial tuberosity around 15 centimeter you can measure it like that, and the same on the opposite side as well, and this will compare the bulk of checking for the tone of the muscle. For this purpose, first of all, we feel that whether the patient is relaxed or not by feeling with both the palms of your both hands, and then when the patient is relaxed, just put your hands underneath the knee and lift. Ask the patient to get loose and see whether the tone is increased or decreased. The other method is that you can like that wiggle it and see the frequency of movement of the feet. If the tone is very little, the feet will wiggle like anything. Power of muscles. This should be checked in groups. It's very difficult to check the power of muscle as far as individual muscles are concerned. Now we examine the power of the muscles of the upper limb. For this, the shoulder muscles, the three important movements, or rather four important movements, are abduction, adduction, external rotation, and internal rotation. For abduction, we ask the patient to push apart his limbs and you press it down, and that's abduction. For adduction, you ask the patient to bring the down and you push it against. Ask the patient for flexion, and that is for extension. For wrist, ask the patient to put the wrist up and you press it down, and for flexion of the wrist, you ask the patient to push it down and you flex it up. As far as the interosseae are concerned, you place a piece of paper between the two and try to and make feel whether the patient can hold it or not. Similarly, you check it in all the digits. As regards the abduction, adduction is concerned, ask the patient to like that and then close it. Open karo. Try to bring them, try to bring them together, and that is okay. And ask the patient to open it, follow, try to bring it together. As regards the thumb movements are concerned, it should be important that the patient palm should be facing the ceiling and it should be placed on a flat surface. Feel that this is a neutral position. If the patient brings his thumb to the radial side of the palm, that is adduction. If he lifts his thumb up and it faces the ceiling, that is called abduction. If he brings it back, that is called extension. If he brings it like that, that is called flexion. And if he touches his fingers, that is called the movement of opposition. And if he moves his thumb like that, that is called circumduction. Abdominal muscles, we ask the patient to lie down in a supine position, put the hands on the front of the chest and try to lift the head up, and you can see that the abdominal muscles, they contract. As far as the erector spinae or the back of the trunk muscles are concerned, you ask the patient to lie prone with his hands by the side, and then ask him to put his hands on the back and lift the head up, and you can see that the erector spinae muscles, they tense up. Lift it up. So this is the way to check the erector spinae muscles. Okay. Continuation of the power of the muscles. As you know, we check the power of the muscles in the upper limb. Now we go to the muscles of the lower leg. For this, we have to do that in the groups. As far as the adductor of the thigh are concerned, we ask the patient to push apart his thighs and we press it inwards. As far as the adduction is concerned, we push it outwards and the patient pushes inside. As far as flexion is concerned, we ask the patient to lift the leg up, down, and we try to push it down. And as far as the extensors are concerned, we ask the patient to push the leg down and we feel it. Now we come on to the rotators of the thigh. We ask the patient to flex the leg like that. Now, if we ask the patient to keep those 2 feet together and move apart his legs. This will check the external rotators. And then we ask the patient to keep in touch both the knees and push apart his legs as far as he can do, and this will test the internal rotators of the thigh. Then we check for the flexors of the knee. अपनी तरफ खींचो, अपनी तरफ टांग को, and we put force in the opposite direction, and then we ask the patient to straighten the leg for checking the extensor of the knee. सीधा करो, टांग सीधी करो, शाबाश. Then we check the dorsiflexors. Put ऊपर करो, no, पाँव को, and then we push it down, and then नीचे दबाओ, and then we push it up. Then we ask the patient to push it in, पाँव को ऐसे करो, and we push it out. This is inversion. बाहर को निकालो, and that is eversion. Coordination of the movement makes another important aspect of the clinical neurological examination. First of all, we check the coordination in the upper limb. In this, we can ask the patient to extend his arm, flex his other fingers, but point out his index finger, and he should touch his nose. And see how frequently he can do that and how accurately he can do that. Do on the same side. उधर करो. हाँ, ठीक है. The other method is that you ask him to touch the tip of your finger, मेरी करो, और अपने नाक को लगाओ, and then touch his nose. Touch the finger and touch his nose. And it is also important to keep on changing the position, that whether he can follow it or not. And he can do that on the other hand as well. And the other method is that he can bring 2 fingers together. दोनों fingers लो, फिर करो, and he can touch it easily. This is called finger method or finger nose method. To check the coordination in the lower limb, we perform a test called heel shin test. In this, we instruct the patient beforehand and then we elicit the test. Ask him to lift his foot up and see whether he can. First of all, he will lift his foot up and try to touch your finger. And during this lifting, you will be able to know that whether he has got any problem with the coordination or not. Then ask him to put the heel on the opposite knee joint, and then slide it down, and then lift again, and then put it down. So do it again. So step number 1, step number 2, step number 3, step number 4. So heel shin test is done in 4 steps, and you can repeat it on the opposite side to find out any discrepancy. Now we come on to the chapter on reflexes. Now the reflexes are of 2 types, superficial reflexes and the deep reflexes. How do superficial reflexes I will elicit a couple of them. The most important reflexes are the abdominal reflexes. In this, the patient is lying supine on the bed, a bit relaxed. Make sure that the atmosphere is not very cold, otherwise the patient will start shivering. Take a sharp object. In my hand is a toothpick which is not very sharp, and what you do is you scratch from outside to the inner side, the abdomen, and you see the contraction of the umbilicus and the movement of the umbilicus. You can see that when I scratch, the umbilicus moves on the same side, and you can note down any asymmetry which will tell you which segment of the abdomen is affected. Now we go on to the plantar reflex, or also called Babinski sign. In this case, we make sure that the patient is relaxed and he is not too tense at all. With a sharp object, we start from the heel, from the outer side, and then we bring over towards the inner side and see the response of the great toe. Normally there is plantar or there is no response, which is called equivocal. But if the great toe goes up, then it is called a positive plantar reflex, or is called extensor plantar response, which is abnormal. Now, depending upon the severity of the disease, this response sometimes is very sensitive, and you can elicit not only with a classical way, but you can also scratch the outer side of the sole, and you see that the great toe moves up. That is called Shattuck's sign. And if you want to elicit Oppenheim sign, then you make a pinch of your left hand, and with the crest of the tibia you slide it down like this forcefully, and the patient great toe goes up. And the fourth way is the Gordon sign. In this case, you squeeze the tendo Achilles, and you see that the great toe of the patient goes up in the form of a positive extensor response. Move on to the deep reflexes. If we start from the head, then the first is the jaw jerk, which I have already demonstrated. The next jerk is the biceps jerk. In this case, semi-flex the forearm at the elbow and semi-prone the forearm at the wrist, and put the thumb of your left hand, and with a hammer just strike it like an arc, and you can see that its biceps muscle contracts and moves the arm with a positive biceps jerk. You compare it on the opposite side and see the response. Triceps jerk. As regards triceps jerk, you flex the patient elbow across the abdomen, and with this you just push your hammer 2 to 3 centimeters above the olecranon process on the triceps, and the patient arm, due to the contraction of the triceps muscle, patient arms is extended. As far as the supinator jerk is concerned, semi-flex the forearm and slightly extend the wrist like this and strike on the supinator muscle, and you can have a supinator jerk. When we go down to the knee jerks, there are 4 methods to eliciting the knee jerk. First is that you semi-flex the knees and ask the patient to put his weight on your left forearm, and then with this you strike on the tendon Having felt the tendon first, that is the method number 1. The method number 2 is that you make an anchor of the right knee over the dorsal surface of your left hand, and the hand is placed on the opposite knee, which will flex this right knee. Now ask the patient to relax, and then you just strike, and you see the contraction of the quadriceps muscle. And this way, you put your hand like that, lift the left knee up, and again strike, and you can see the contraction of the quadriceps muscle. And the other method is that you ask the patient to sit at the edge of the bed with his legs hanging down, and ask him to relax, and with the head of the patellar hammer you strike, and the patient leg moves. It is good idea to elicit pendicular or pendicular jerks, especially in case of cerebellum. As far as the ankle jerks are concerned, there are 4 methods to demonstrate the ankle jerk. The classical method previously we used to adopt was a figure of 8 or a frog's position. In this case, you extend, and on the tendo Achilles you strike, and you can elicit the jerk. Similarly, you can do like on the opposite side. But this is inconvenient to the patient and looks pretty odd. The other method is that you put the leg on which you want to demonstrate the ankle jerk on the shin of the opposite leg, extend the ankle and strike it. Now this gives you a better view, a better field of striking, and the limb is not going to hinder. Similarly, you can do it on the opposite side like that. The third method is that you make your left hand placed on the forefoot, and then you extend the forefoot and you strike your fingers, and the patient's ankle jerk is elicited. Now the fourth method to elicit the ankle jerk is to ask the patient to kneel on a chair with his feet hanging outside the edge of the chair. He should be very much relaxed, and what you do is you just strike the hammer like that, and these ankle jerks are elicited. This is very important to elicit, especially in case of if the patient has got hypothyroid. Mind you, as far as the deep reflexes are concerned, you should, before you proceed to this procedure, tell the patient what you're going to do, because sometimes when you hold a hammer in your hand and you approach towards the patient is scared. And make sure the environment is warm, the patient is in full confidence, is relaxed, and tell him that it's not going to hurt him striking on your own hand or wrist, and the patient gets into more confidence. And these jerks or these tendon reflexes, if you are unable to elicit, you should elicit on both the sides. If you are unable to elicit, then you adopt the method of reinforcement. You give a patient to a task, and then you go ahead with that. An important aspect of the logical examination is the determination of the gait. It is important to ask the patient to walk, whether the patient can walk straight or whether the patient lurks on one side or other side. So it's very important to ask him to walk. It's called tandem walking. In this case, you ask the patient to put one heel of his foot in front of the other forefoot like this, and ask him to walk on a straight line, whether the patient can walk like that or not. That is called the tandem walking. Now, having said that, there are different types of gaits which we come across. In case of Parkinsonism, it's called festinant or festinant gait. In this case, the patient stoops forward as if he's rolling around his center of gravity and shuffling. He shuffles like that on his forefeet. And if you push him from behind, then he falls forward, called retropropulsion. And if you push him from front, then he will go back and he will fall backwards, called retropulsion. The other gait is a classical gait of hemiplegia. In this case, the patient, say for example, the patient got right hemiplegia. He's got his arm flexed at the elbow, the wrist is flexed and the fingers are like that with the thumb inside, and he will walk with an arc like that with his feet touching the ground. I can demonstrate it again. This is a hemiplegic gait. Okay. Stamping gait is also called sensory ataxia. In this, the patient has got no sensation of the ground and lifts his foot like that and places like that. It's called stamping gait. In spastic gait or cerebral palsy, it's also called scissor gait. In this case, the patient will be crossing his legs when he walks. That is called scissor gait, like a scissor. In case of waddling gait, which is usually due to the hip problem, the patient waddles like a duck. It's called waddling gait. In case of cerebellar ataxia or cerebellar gait or drunken gait, the patient falls like that. And in case of ataxia basia, there is no pattern of the gait at all. And in hysterical gait, the patient tends to fall, but patient never falls. As far as colonus is concerned, to check that we have two options, either at the patella or at the ankle. To check the patellar colonus, we squeeze the skin of the patella upwards like that, and then we push it downwards and forwards like a jerk, and we see that the patient's patella starts moving. I do it again. Squeeze the skin like that, hold it tightly, and you push it downwards, and the patient patella moves like that. In case of ankle colonus, make the knee flexed at the right angle and hold the forefoot of the patient's right foot with your right hand, and with holding like that, forcefully dorsiflex the ankle, and the patient's ankle will start jerking, and that is called ankle colonus. Right, we come on to the sensory system, in which you check the superficial sensation and the deep sensation, especially the sensation of the touch and vibration, sense of position, and sense of pain. Now, as far as the touch sensation is concerned, you should be well aware of all the dermatomal distribution of the sensory system. In this case, we use a cotton wisp and we touch on both sides along with the dermatomes. If we are checking the skin of the chest, and then the cervical, the deltoid area, then this area of the cervical chains, and the finger as well. So we do it on the both sides. Now, as far as the lower limb is concerned, this area which is inguinal is L1, that is the L2, the pocket area, the L3, the L4, the L5, and S1. And then we can touch with a toothpick or any sharp object for the sensation of the pain, making sure that you don't hurt the patient too much. As regards sensation of temperature, we have two bottles in which one is hot water and one is cold water, and you alternate touch on the dermatomal distribution of these, as I said before. And as regards the vibration sensation, we use a tuning fork. We use a tuning fork of 128 Hertz, and we strike and we put it in the forehead to see whether he can, especially these are put on the bony prominences, or we can put at the patient's thumb on both sides whether he can feel any buzzing or not. We can put it on the anterior superior iliac spine on both sides, or even at the tibial tuberosities, and even at the medial alveoli, and whether patient feels it or not. As regard the sense of position, it's important to remember and the proper way to demonstrate it. We usually choose the great toe. In this case, with the other hand, we remove the other toes so that they should not touch with the great toe, and we hold the great toe from the side, not like this. We hold it from the side to stimulate the minimum sensory area, and we first of all wiggle the toe, and then we move in small installments, and then we ask the patient whether the toe is down or is the toe is up. If a patient is able to tell you the right direction, it means the sense of position is intact. We can do that. Always remember to compare the finding of one side on the other side. Move on to the cortical sensation. In this, there is a sensation of tactile localization. In this case, we ask the patient to close the eyes, aankhein band karo, and then touch with a cotton wisp any part of his body and ask him where did it touch. Tactile discrimination, the patient is able to discriminate between the 2 points of the prongs, and different parts of the body vary in the capacity of finding out the distance between the 2 prongs. The very sensitive area can even distinguish between 2 to 5 millimeter, whereas some areas the distribution is more than 3 to 5 centimeters. And then there is a sensation of graphesthesia. Ask the patient to shut the eyes and write something on the palm with your finger and ask what has been written. And this will tell us the sense of graphesthesia on both sides. And then you put some sort of thing in the patient's hand and ask him to find out what is it. Say for example, put that in hand, feel it, महसूस करो, महसूस कर इसको, feel कर क्या है ये. Similarly, आंखें बंद, क्या है ये? चाबी. So he's saying that this is a bunch of keys. So you give a patient different objects and you ask him what does he feel. Yes, pencil. So he says that it's a pen. The stereognosis is intact. Cerebellar disease. Quite a few signs they have already been demonstrated. Especially I can recapitulate them. In this case, first of all, we look for any nystagmus, look for any disturbance in the speech, which is a sort of a different type of speech or slurring of speech. Then we look for any incoordination like finger nose test or finger test. Then we look for any incoordination in the lower limb in the form of heel shin test. Then we elicit the pendular jerks, and we can also do the dysdiadochokinesia. Now dysdiadochokinesia, in this case you ask the patient to roll a bulb with his hands like that, so that we can see that the movements are coordinated, they are not like this or incoordinated. The other test is called the palm test. In this case you ask the patient to hold the palm like this and with the other hand do alternate tapping movements and see how rapidly he can do that. Similarly, on the opposite side you can see that. Obviously the hand which is dominant hand will. Sign is again an important sign for sensory ataxia. In this case we ask the patient to stand with eyes open and see whether the patient can stand normally or not. In this case he is standing normally, and then we ask him to shut the eyes and you see whether this patient sways in any direction or not. If the patient with closed eyes sways in any direction, it means the Romberg sign is positive. Now we come on to the signs of meningeal irritation. which are demonstrated to rule out any evidence of meningitis or meningoencephalitis. In this case, we see the patient is lying supine in the bed. What we do is we put the right hand of the front of the chest, and with the left hand at the back of the chest, we lift the patient's head up, and if there is stiffness, he will be unable, or we will be unable to touch the chin of the patient on this head. And at the same time, the patient is in so much pain that he can flex his both knees. That is called positive Kernig sign. The other sign is Brudzinski sign. In Brudzinski sign, we flex the leg at the hip joint, and then we extend at the knee joint, and we see whether the patient gets pain. The pain is so severe that the patient flexes the other leg as well.